Hi guys, welcome back. So pardon my little hoarse voice. I hope all of you are doing good. And today we will be taking up important questions from nephrology. And when it comes to nephrology, for the prof exam, what are the important areas? The majority of the questions are going to come from either AKI or CKD. And apart from that, some questions may be from glomerular disorders. The questions may be clinically oriented, may start with a clinical stem, asking you to diagnose the pathology and then progress to discuss about AKI or CKD, right? So we'll start with the first AKI. Here's the question. Define acute kidney injury, classify and enumerate causes for acute kidney injury, and then how do you differentiate between prerenal AKI and acute tubular necrosis? Now, objectively, what a teacher is looking for when they are assessing an answer paper on acute kidney injury. Of course, basic classification is required into renal, prerenal, and postrenal. But most importantly, we are very precisely looking at the definition or criteria for AKI, whether you get the numbers right. Because, like, if the definition is clear, already examiner has made a positive mindset, knowing that okay, the guy knows the stuff well, and the rest of the things he will quickly glance and give you the marks and move forward. So when do we call it as acute kidney injury? The definition or the diagnostic criteria has three parameters defined, and we have to mention all of them. The first one is increase in serum creatinine by more than or equal to 0.3 milligrams per deciliter within 48 hours. Within 48 hours. So what does that mean? It means whatever was the baseline creatinine value. Let us say I have an individual with a creatinine of 1.0, and when I check it, let us say after 24 hours, it is 1.4. So how much increase has happened? The increase is 0.4. And within how much time span this has happened? Let us say this has happened in 24 hours. Does this fit the criteria for AKI? Yes. What the criteria said? Increase in serum creatinine by more than or equal to 0.3 milligrams per deciliter within 48 hours. Okay, well, I have a patient whose creatinine is high, but it does not fit this criteria. Then I should see whether it fits the other two criteria to call it as AKI. The second parameter is increase in serum creat by more than or equal to 1.5 times baseline. What do I mean by that? Whatever is the initial value, like let us say in this exam it was 1 in this example. 1.5 times this means multiplied by 1.5, that will become 1.5 itself. So if it becomes 1.5 times the original value or the baseline value within 7 days or 1 week, then also you can call it as acute kidney injury. That's a second criteria. The third one is based on urine output, because good evening Ganjan. Because not all renal dysfunctions are related to rise in creatinine or urea. Even decreased urine output also means that the kidneys are dysfunctional. So that's why the third criteria is based on urine output. Urine output less than 0.5 ml per kg per hour for more than or equal to 6 hours. Then we can call it as AKI. Means, okay, now let us say I have a patient who is hospitalized in the ward for surgery or something, and we are constantly monitoring the urine output. So morning 8 a.m. to 9 a.m. the urine output was 30 ml. The patient is 100 kg. So you should have 0.5 ml per kg. So 100 kg person should have at least 50 ml urine output, but this fellow had only 30 ml. 8 a.m. to 9 a.m. 9 to 10 a.m. staff nurse again checked, it is 20 ml. She checked the next hour, it's again 20 ml. She checked the next hour, it is 30 ml. So consistently for 6 hours, the urine output is less than 0.5 ml per kg per hour. Then also we'll call it as acute kidney injury, right? So these are the three parameters. Teachers are objectively looking for these numbers. You have to by heart this and mention it in the answer sheet. Okay. So after defining the acute kidney injury, though in this particular question they have not asked you to stage, but your university paper might ask you to stage the acute kidney injury, and we are using the same parameters for staging. Means we are looking at serum creatinine and urine output. So there will be three major stages of acute kidney injury according to the KDIGO staging. So we'll call this staging as the KDIGO staging of AKI. It's called as KDIGO staging of AKI. So we will have the creatinine based staging and urine output based staging, because we might have diagnosed the acute kidney injury either based on increase in creatinine or decrease in urine output. So first let us look at the creatinine based staging. When our creatinine increases by 0.3 milligrams per deciliter within 48 hours, or it increases by more than 1.5 times the baseline within 1 week, we call it as AKI when it comes to creatinine, right? So same thing we are using here. If creatinine is increased more than 1.5 times, but it is still less than 2 times the baseline, then it is stage 1. Means 1.5 to 1.9 times the baseline is stage 1. But if it is more than 2 times or higher, up to 2.9 times the baseline, we will call it as stage 2. And if it becomes 3x, like let us say the initial creatinine value of this individual was 1 milligrams, but now it is 3.2. How many times it has increased? 3.2 times it is increased. It is more than 3x. Then it will be called as stage 3. It will be called as stage 3. And examiners are particularly interested in knowing one important point. Any patient of kidney injury, acute kidney injury we are talking about, if you start them on renal replacement therapy, what do you mean by renal replacement therapy? We are referring to dialysis. So irrespective of the creatinine value, irrespective of the urine output value, if someone is started on dialysis, will always be considered as stage 3. There are so many indications for starting dialysis. If the potassium is very high, or if there is acidosis which is not responding, we might initiate the patient on dialysis. Then we will start labeling it as stage 3, right? So I want you to have an understanding of the staging, because during your viva OSCE, your teachers might ask you to stage. So simple thing is, the baseline creatinine, let us say, is 1. So when it becomes 1.5 to 1.9 times the baseline, we will call it as stage 1. And 2 times to 2.9 times the baseline, we will call it as stage 2. Right? More than or equal to 3x the baseline, we will call it as stage 3. And also any patient started on dialysis is also stage 3, irrespective of the urine output or the creatinine, right? So I hope now we have a little clarity on the definition of the acute kidney injury as well as the staging. Now let's come to the main part of the question. How do we classify the causes for acute kidney injury? Now when we look at the kidneys can go dysfunctional not only because of the problem at the level of kidney. The problem may be before the kidney or after the kidney, right? So for understanding that, we need to have the fair idea about the renal functioning. So we know that kidneys primarily receive the blood supply from the renal arteries, filter the blood out of it, and produce what we call as urine. So urine is the end product, and to produce that urine, we need to have a good blood flow to the kidneys, which comes through renal arteries. And if I have any decrease in the blood flow to the kidneys will not be able to filter out. So sufficient urine production won't happen, sufficient creatinine clearance won't happen, sufficient urea clearance won't happen. So urea, creatinine, and all other metabolic waste products will stay back in the blood creatinine level will increase, blood urea level will increase. But why is this happening? Is the kidney actually damaged or dysfunctional? No. If I have just reduced the renal blood flow, kidneys can become dysfunctional. So if the problem is because of decreased perfusion of the kidney, we will call it as pre-renal. Okay, that's one level of problems. Second, at the level of kidney itself, you may have the problem. The glomeruli, the tubules, they may become dysfunctional and you may end up with acute kidney injury. The third one is, let us say the blood coming to the kidney is unaffected. Kidney's filtration process, the glomeruli, tubules, all of that is undisturbed. But once the urine is produced, it exits the kidney through the ureters to reach the bladder, and then through urethra to the external environment. So in the outflow of urine from the kidney to bladder or from bladder to the external meatus, if there is any obstruction, behind the obstruction pressure starts building up and the kidneys start becoming dysfunctional. So we'll call that as post-renal. So the causes for acute kidney injury where creatinine will rise by 0.3 milligrams per deciliter or higher within 48 hours, or 1.5 times the baseline within 7 days, or urine output drops by less than 0.5 ml per kg per hour for 6 hours. This may happen because of decreased renal blood flow, or the problem with the kidney, or obstruction to the urine outflow from the kidney. So when there is obstruction to the urine outflow from the kidney, those causes will be labeled as post-renal acute kidney injury. These are the most easiest causes to diagnose, because do an ultrasound, it will find out if there is a stone or any like bilateral ureteral obstruction, urethral stricture, right? Bladder outlet obstruction. Any of these can be mostly easily picked by ultrasound, or if not, the CT scan. So the post-renal, the common causes are bladder outlet obstruction, outlet obstruction. This could be because of a tumor, massive prostatomegaly, or many other causes. Bladder outlet obstruction, or it could be also because of bilateral ureteric calculi. Ureteric calculi. Okay, so these are the only two causes I want you to write for post-renal. Now let's talk about the pre-renal. Pre-renal refers to decreased renal perfusion. Decreased renal perfusion. So if the blood itself is not coming in sufficient quantities for the kidney, then how the kidneys will be able to filter the urea, creatinine, and other metabolic waste out from the blood? Now, in what circumstances the renal perfusion decreases? The renal perfusion can be decreased because of due to decreased cardiac output. That's one cause, due to decreased cardiac output. Now tell me, in what circumstances the cardiac output will be decreased? N number of causes are there, right? It could be at the level of heart. It could be related to low circulating volume. So plenty of causes are there. So decreased cardiac output can happen because of left ventricular failure. And when heart fails and because of that kidney start losing the function, we can also call it as cardiorenal syndrome. So it could be because of left ventricular failure. It could be because of hypovolemia. This hypovolemia, the loss of volume of blood, could be because of blood loss, dehydration following uh, water restriction, or a dehydration because of acute gastroenteritis. All of these are causes, right? Blood loss following trauma, blood loss during surgery, or spontaneous bleeding because of coagulopathies. And the other cause where you can have decreased renal perfusion is your heart is fine, your blood volume is fine there, it is pumping well, but then your renal arteries are stenosed. Renal artery stenosis. Okay. Then another condition where decreased renal perfusion can happen is impaired renal autoregulation. Impaired renal autoregulation. Now, what do I mean by this? So when we talk about the blood flow to the kidney, we should know that it is regulated. Precisely means even when BP is dropping, kidneys make sure that they get the decent enough of blood supply so that they can keep the process of filtration running. So we know that at the very microscopic level, the functional unit of a kidney is a nephron, and a nephron has what we call as glomeruli, right? Through which the intraglomerular pressure is the one which is driving the process of filtration. And if the amount of blood coming to the kidney comes down, there is no sufficient filtration process, a filtration pressure. I need the pressure inside the glomeruli to be able to filter the blood. And it is directly proportionate to the volume of blood entering the glomeruli. But for some reason, like let us say I have not taken sufficient fluids for last 24 hours, I'm getting dehydrated, then my blood volume should start shrinking. So because of that, the amount of blood entering the glomeruli should start coming down. So kidney's function should start getting disturbed. But kidney tries to counter that. How? You know, the blood enters the glomeruli through what we call as an afferent arteriole and leaves through an efferent arteriole. And despite decreased flow, if I want to have good intraglomerular pressure for filtration, what should I do? I can do two things. One, I can cause the dilatation of the afferent arteriole. So if I dilate the afferent arteriole and constrict the efferent arteriole, if I narrow it, the efferent arteriole is constricted, and I dilate the afferent arteriole, I make it wider. In that case, the blood easily enters, or more blood enters, because the afferent arteriole is dilated, and because efferent is constricted, it can't leave the glomeruli easily. So pressure inside the glomeruli builds up further, and that facilitates the filtration even when you are going through some degree of hypovolemia. But how do I dilate this afferent arteriole, and how do I constrict the efferent arteriole? The efferent arteriole is mainly constricted by angiotensin 2, and afferent dilatation is mediated by various mediators, but the one that I want you to remember is prostaglandin I2. This is the reason why I'm talking about it. And you might have studied that when you studied in pharmacology, that AC inhibitors or ARBs, when there is bilateral renal artery stenosis, if they are prescribed, they lead to worsening of renal function. Why? Because if I give AC inhibitors or ARBs, I lose my ability to constrict the efferent arterioles because I'm blocking it. So for some reason, if there is some degree of dehydration and the blood flow to the kidney decreases, I can't constrict the efferent arteriole. So then I may not be able to get sufficient intraglomerular pressure for filtration, and the filtration function gets disturbed, right? Similarly, we know that NSAIDs are nephrotoxic agent, right? Diclofenac, all of that. One of the mechanism for their nephrotoxicity is inhibiting the prostaglandin I2. So when I inhibit the prostaglandin I2, then I may not be able to dilate the afferent arteriole. So any small degree of dehydration, kidneys generally counter that by afferent arteriole dilatation and efferent arteriole constriction. But in presence of NSAIDs, we may not be able to do that. So we are losing this autoregulation when we are on NSAIDs, or when we are on AC inhibitors or ARBs, right? So impaired renal autoregulation can happen as in case of use of non-steroidal anti-inflammatory drugs. So these are the important pre-renal causes for AKI. Among them, hypovolemia, regardless of the cause, means all causes, blood loss, dehydration, all causes put together, hypovolemia is the most common cause for pre-renal AKI. Okay. So after the pre-renal, now let us talk about the intrinsic renal. Okay. Now let us say the blood flow to the kidney is fine. The outflow of urine from the kidney is undisturbed. The ureters, bladder outlet, urethra, external penile meatus, everything is fine. Still, you may get AKI if things are wrong inside the kidney. What can go wrong inside the kidney? So when we look inside the kidney, there are several structures which can be affected by diseases. And as you know, the structural and functional unit of the kidney is a nephron. And a nephron comprises of glomeruli, Bowman's capsule, then Bowman's capsule, proximal convoluted tubule, loop of Henle, and distal convoluted tubule, collecting duct. This makes up for one unit of renal function, that is kidney. It will have an afferent arteriole, efferent arteriole, and a glomerulus. Okay. Now, this structure is a glomerulus. Along with that, you have these tubules, PCT, DCT, loop of Henle. These are called as tubules. And all of them are held together. The glomeruli, tubules, all of them are held together by the connective tissue. This connective tissue, we will call it as interstitium. Interstitium. So diseases may affect glomeruli. You are already familiar with which diseases affect the glomeruli. In fact, in their name only we will have chronic glomerulonephritis, post-streptococcal glomerulonephritis. So the name itself will have generally glomeruli mentioned. So those are glomerular disorders. Then you also have tubular disorders. What affects the tubules? Some drugs can precipitate inside the tubules, block the tubules, cause the necrosis of the cells or the epithelium lining the tubules. Tubules are dead. Then the filtration process gets disturbed. So tubular disorders is second set. Third, this connective tissue which is holding the nephrons together, they may get affected by the diseases. So interstitial diseases. And within the kidney, see, the renal arteries are large arteries which are entering the kidney. But once the blood vessels enter the kidney, within the kidney they are branching to go to the different areas. So if there is some problem in the blood vessels, you can still have the kidney dysfunction. So the intrinsic renal causes for AKI will be divided into glomerular disorders, tubular disorders, interstitial disorders, and intrarenal blood vessel related disorders, right? So what glomerular disorders usually present as acute kidney injury? So the First example I want you to write as a presentation for acute kidney injuries: post-infectious acute glomerulonephritis, usually abbreviated as PIGN, post-infectious glomerulonephritis. And your PSGN that we are aware of, post-streptococcal glomerulonephritis, is nothing but one of the post-infectious Sutapa Samantha, I think Kamran Bhatt has already answered your query. So NSAID is because they reduce the prostaglandin I2 synthesis, and prostaglandins are vasodilators. They are required for the afferent arterial dilatation whenever we need to increase the blood flow to kidney. So if I am taking NSAIDs, I am losing that ability to cause the afferent arterial dilatation. And if I have some dehydration, I don't have this defense available for me. So that's why we can develop acute kidney injury. Okay. So post-streptococcal glomerulonephritis is one. The other example we can quote is IgA nephropathy. So these are glomerular disorders. Okay, can anybody comment and tell me how a patient of glomerular disorder presents? What are the presenting complaints of a patient who has got glomerular disorder? The rise in creatinine we'll get to know only when we do blood investigation. But how do they come to us? Okay, so when it comes to tubules, the tubules can be damaged by drugs. And like for example, acyclovir. If you give high dose acyclovir IV especially, the acyclovir tends to precipitate as crystals in the renal tubules. PCT, DCT, loop of Henle, it gets precipitated there and causes the necrosis of those tubules. Then we have, within the tubule, we have something called as acute tubular necrosis. More on that we will discuss later. Then when it comes to interstitium, the interstitium can be inflamed and cause the renal dysfunction. In that case, we will call it as interstitial nephritis. Interstitial nephritis. Most of the times, the connective tissue of the kidney gets inflamed as part of an allergic process. So the most common cause for interstitial nephritis is drug allergies. And I also want you to remember that the most common drug class known to cause drug allergy and thus become a reason for interstitial nephritis is going to be beta-lactam antibiotics. Beta-lactam antibiotics. Various other class of antibiotics are also known to cause. Beta-lactam is something that I want you to remember. So penicillin, various forms of beta-lactams can cause the allergy, and as part of the allergy, even the connective tissue of the kidney gets inflamed. So you thus have an acute kidney injury. Then intrarenal blood vessels getting affected. It can happen in various conditions. So one of them I want you to remember is thrombotic. It's a broad term per se. Thrombotic microangiopathies. Thrombotic microangiopathies, where there are formation of small clots in small blood vessels. It's called as thrombotic microangiopathies. A classical example for thrombotic microangiopathies, you might have heard about the TTP hemolytic uremic syndrome. Apart from that, even the disseminated intravascular coagulation. So here I want you to mention two examples: the thrombotic thrombocytopenic purpura and hemolytic uremic syndrome, and disseminated intravascular coagulation, or DIC. See, DIC is such a common complication these days we encounter in ICU. Patients with sepsis, multi-organ failure, polytrauma. So in them, there is generally endothelial dysfunction. Right? Let me just give you a brief idea about what is this DIC or what happens in DIC. So basically what happens is when you have sepsis or when you have like overwhelming infection, a body produces large amount of inflammatory cytokines like interleukin 1, interleukin 6. And these inflammatory cytokines will cause endothelial injury. And when there is endothelial injury, we know that if I cause endothelial injury, once there is endothelial injury, we are exposing the von Willebrand factors. And once von Willebrand factors are exposed, the platelets will come and adhere. So platelet adhesion happens, then platelet aggregation, fibrin clot formation. So endothelial injury, as you know, is part of the Virchow triad, one of the risk factor for formation of clot. So once the endothelial injury happens, you will develop microclots in blood vessels. And once we develop microclots, multiple blood vessels, small blood vessels are developing clots. That can happen in the lungs, in the liver, in the limbs, as well as in the kidneys. So if the kidneys develop that, the kidneys function gets affected and we end up with acute kidney injury. And here again, because microclots are happening, the platelets are getting used up in forming these clots. So because of that, you will have decrease in platelet count. And also the coagulation factors are getting used up in forming these clots. So you have the decrease in clotting factors as well. And because you're losing the clotting factors, despite developing these microclots in blood vessels, patients start bleeding. So they may even bleed to death, which is like a very difficult to manage complication of systemic inflammation that we see in ICU. So as part of this, patients might develop acute kidney injury. So the classification of causes of acute kidney injury, I want you to put this flow chart. So acute kidney injury will be classified as prerenal, intrinsic renal, and postrenal. Prerenal is because of the decreased renal perfusion. It could happen because of renal artery stenosis or impaired renal autoregulation of blood supply, or it could be because of decreased cardiac output due to left ventricular failure or hypovolemia. Hypovolemia is overall the most common cause. In our day-to-day practice, most of the times it is because of severe dehydration, which could be part of blood loss or volume loss due to acute gastroenteritis. So if you see a patient of acute GE in the ward having high creatinine, you know that he has developed prerenal AKI because of hypovolemia. The intrinsic renal causes we will divide into glomerular disorders, tubular disorders, interstitial disorders, and intrarenal blood vessel disorders. So intrarenal blood vessel disorders, thrombotic microangiopathies are one. The other one is vasculitic syndromes. When it comes to vasculitic syndromes, it could be like polyarteritis nodosa or cryoglobulinic vasculitis. They may present with acute kidney injury because blood vessels are getting inflamed. Interstitial nephritis is most commonly because of drug allergies, and the drug most common class associated with these drug allergies is going to be beta-lactam antibiotics. Inner myself, it all depends on what drives your passion. So if you're passionate about anything, there is no age bar as such. You can start anything at any age. People have started running marathons after 70 years of age and they have even completed it. So there's nothing impossible, but it depends on what drives you. So if you have that enthusiasm, don't hesitate, join. Okay, so now we have understood the classification of causes for acute kidney injury. So what we have studied so far, we have learned the diagnostic criteria or definition, the staging, and the classification of causes. I'm just adding a small table here. This is for MCQs, as well as some universities have 3 marks questions asking you to enumerate the drugs causing acute kidney injury. So here also I have classified them based on their site of damage. So the drugs causing the tubular injury includes aminoglycosides, vancomycin, amphotericin B, acyclovir. So I gave you the example of acyclovir. Acyclovir forms the crystals and precipitates in the tubules and causes a tubular injury. Then the antiviral drug tenofovir used for hepatitis B and HIV, and the cancer chemotherapy agent cisplatin. The drugs known to cause interstitial nephritis, I told you drug allergies are the most common cause. And when it comes to interstitial nephritis, it could be caused by beta-lactams, NSAIDs, and sulfur drugs. And I've already told you that beta-lactam antibiotics are the most common cause for the interstitial nephritis. Some drugs are known to trigger the thrombotic microangiopathy by causing the endothelial injury, like bevacizumab. It is called as an anti-angiogenesis drug. It inhibits the blood vessels proliferation or growth, but by doing so, it causes endothelial injury, and endothelial injury might trigger thrombotic microangiopathy. Thrombotic microangiopathy will affect the intrarenal blood vessels, and you can have acute kidney injury. So now that we know the causes, let us see how do I evaluate the causes for acute kidney injury. Someone came to me with decreased urine output, or someone came to me with increased creatinine. How will I evaluate? History does hold an important role because history gives us the clue whether this patient is likely to have a prerenal AKI, renal, or postrenal. At the same time, if it is renal, the history may also tell us whether this patient may be having glomerular disorder or tubular disorder or interstitial nephritis. Right. So what are the points I should be looking for in the history? History of hypovolemia. Why is this important? What history I should ask? Whether patient had any acute gastroenteritis or acute blood loss. What does this point towards? This points towards the possibility of pre-renal AKI. Because if I lost, like I had a road traffic accident, I bled 1 liter of blood. After that, my creatinine is high. You know, it is pre-renal AKI, right? It is suggestive of pre-renal AKI. Then second thing you are looking at is history of periorbital edema. So if someone's creatinine is high and he gives the history of periorbital edema, presence of hematuria and hypertension. What is it pointing towards? It is pointing towards acute nephritic syndrome, right? It is suggestive of nephritic syndrome, and nephritic syndrome may be suggestive of glomerular disorders. It could be post-infectious glomerular nephritis, IgA nephropathy, or any of the other glomerular disorders. Nephrotic syndrome is usually a chronic condition. It does not present as AKI. It presents mostly as chronic condition. Okay, then you should also be concerned with history of drug use, particularly drugs known to cause renal injury like NSAIDs, beta-lactams which cause interstitial nephritis, then aminoglycosides which cause tubular injury. So all these history should be documented. So please mention 2-3 points at least. You should be looking at the history of volume loss, should be looking at the history of nephritic syndrome as a presentation, and should be looking at the history of drug use. That might give you the clues. Further, we have to rely on the investigation. And when we investigate, of course, when we do the serum creatinine and the urea, they're expected to be elevated in a patient with pre-renal, in a case of AKI per se. But beyond that, urine analysis might hold an important role in diagnosis of cause for the AKI. What are the important things that I can get to know from the urine analysis? One is the presence of CAS. Second is hematuria. So now when it comes to the CAS, so if you get to see that there is altered creatinine values fitting into the definition of AKI, so you know that it is AKI. And then when I look at the urine analysis and I see hyaline CAS, hyaline CAS are usually encountered in two conditions: either patient has normal renal functions or in patients with pre-renal AKI. Now, what are these hyaline CAS? Can anybody tell me what are CAS actually? How are these CAS made? How are the CAS made? You know, the kidneys generally do not filter the large molecular weight substances, but some small molecular weight proteins do get filtered out. And we call those proteins as Tom Horsfall proteins. So when we filter to create what we call as glomerular filtrate, this filtrate generally doesn't contain albumin or other large molecular weight proteins. But the low molecular weight Tom Horsfall protein will get filtered. And as it passes through the tubules, it starts getting precipitated and forms a sheet. So this sheet, it generally gets precipitated in the tubule, so it forms that sheet. And that sheet that is formed by precipitation of this Tom Horsfall protein is what we call as a cast. That's a basic cast. Hyaline cast is made of only Tom Horsfall protein. But sometimes the other cells may get added to this Tom Horsfall protein sheet, and then we will name them differently. Tom Horsfall protein cast is normal. It will be seen in your urine, my urine, and everybody normal individual's urine. So if you are normal or you have pre-renal AKI, you get only hyaline cast made of Tom Horsfall protein. But if I have glomerular injury, then what happens is, as the glomeruli get damaged, the RBCs get passed on through this injured glomeruli into the glomerular filtrate. So that will manifest as hematuria, one thing. Second thing is these RBCs will be impregnated on this Tom Horsfall protein sheet. Now, this hyaline cast has RBCs impregnated onto it. So in that case, we will call them as RBC casts. We will call them as RBC casts. So if I see RBC cast, I know that patient has got nephritic syndrome. He has got glomerular injury. So this is pointing towards glomerular disorders. Okay, what else cast can tell me? Now, let us say that I have some tubular injury. Acute tubular necrosis because of decreased blood flow, or acyclovir getting precipitated here and causing the tubular injury. Now, if I cause the tubular injury and the tubular cells get necrosed, so these tubules are lined by epithelial cells, and these cells get necrosed, they shed off, and once the epithelial cells are shed off, they will also float in the filtrate, and they will also get impregnated on these sheets of Tom Horsfall protein. Now I have a cast which is composed of Tom Horsfall protein sheet, and on top of that, the renal tubular epithelial cells are added. This is also new cast. This cast is indicating that the renal tubular epithelium is damaged. That's why the cells are shed and added to this sheet. And we will call them as renal tubular epithelial cell casts. We will call them as renal tubular epithelial cell casts. When does that happen? When there is tubular injury, right? Because the epithelial cells will be shed only when the tubules are injured. And if I catch hold of these sheets fresh, they will appear as the classical renal tubular epithelial cell cast. But if the casts stay for a longer period of time, these epithelial cells start disintegrating. And when they go into apoptosis, they will produce a pigment called as lipofuscin. And because of this pigment, the cast now starts appearing brownish. So in that case, we will call those casts as muddy brown casts. So if I see renal tubular epithelial cell casts and muddy brown cast, it is indicating that the tubules are injured. Then I can take it as a case of acute tubular necrosis. So look at this. The basic urine analysis is giving me clues for further evaluation. So if I saw RBC casts, then I know that it is glomerular disorder. If I saw renal tubular epithelial cell casts or muddy brown cast, then I know it is pointing towards tubular injury. And if I saw only hyaline cast, it is pointing towards either a normal renal function or the prerenal AKI, right? So casts do hold important value. Okay. Apart from that, the urine analysis may also tell me about the presence of hematuria. Now, hematuria can happen because of the injury to the kidney, ureters, bladder, urethra, right? Anywhere. So it is just pointing towards that kidney, ureter, bladder or urethra is injured, and because of that you're losing the blood. But there's one point which helps you to identify whether this hematuria is because of the injury at the level of kidney, to be more precise, whether it is injury to the glomeruli. And what is that point? If glomeruli get injured, the RBCs are now making their way through these injured glomeruli into the glomerular filtrate. But when they're passing through tiny apertures. So when they pass, they get damaged. So you get to see RBCs which are dysmorphic. So if you have dysmorphic RBCs, it is pointing towards glomerular injury. So this is also another point that I want you to mention. So if you see dysmorphic RBCs, it is pointing towards glomerular disorder. So majority cases, we get to know what is the reason for this particular patient's acute kidney injury from the history and basic investigation. All we need to do is get the history. From the history itself, it may be apparent, and if not, then go ahead with the basic renal function test, urine analysis, and maybe imaging to rule out the bladder outlet obstruction or ureteric or urethral obstruction. Now I have one question. Okay. But before I start investigating for acute kidney injury, how do I know that this is AKI only? If I knew the patient's baseline creatinine and then its progression, how in what time span it has increased, then I can confidently diagnose it as AKI. If 0.3 milligrams per deciliter increase in 48 hours in creatinine, or 1.5 times the baseline increase within 7 days, then I know it is AKI. But what if I don't know? how much was the patient's baseline creatinine. He has come to me with some symptoms. I got the creatinine done today. It is definitely above normal, but I don't know how much it was before. So I know only creatinine is elevated. Whether it is elevated acutely to call it as AKI, or whether it was elevated for a long time, whether it is CKD. How do I differentiate? What is the best investigation that helps you to differentiate between the AKI and CKD? How do I differentiate between AKI and CKD? Well, when the kidneys become chronically damaged, there will be fibrosis of the renal structures. The kidneys start shrinking in size. So the best investigation to differentiate between AKI and CKD is going to be USG of kidneys. Do the ultrasound. If the kidneys appear in normal size, that means the kidneys are not being damaged for a long time. So then the raised creatinine is a recent problem. So it's most likely AKI. But if kidneys appear to be shrunken, then it's a long-standing problem. So it is not likely to be AKI. It is more likely to be CKD. Right? You see in this image, this is a normal sized kidney. And as you see here, you can see there is a clear differentiation between the cortex and medulla, and the size of the kidney appears normal. Now compare that with another kidney here, where the kidney is smaller in size and the cortex and medulla differentiation is lost. So if you get a shrunken kidney with, you don't know where is the cortex, where is the medulla, loss of corticomedullary differentiation, then it is suggestive of CKD. That means the creatinine that you're seeing for the first time to be high is probably not high from last few days or 1 week. It's high for months together. You have a case of CKD. But if I get a patient with elevated creatinine or decreased urine output, but the kidneys appear structurally fine, there is no decrease in the size, the corticomedullary differentiation is preserved, then I know it is acute kidney injury. It is not likely to be CKD, right? So if your teachers during viva ask you what is the best investigation to differentiate, you can say ultrasound of the kidney. Okay, so that completes our evaluation of AKI. Now comes the main part. The intrinsic renal causes that we discussed. Glomerular disorders are easy to diagnose. They present with classical history. They will have these classical features of glomerular injury, that is hematuria with dysmorphic RBCs, presence of RBC cast and nephritic syndrome presentation, periorbital edema, hypertension, all those, right? So it's not a challenge. Interstitial nephritis, interstitial nephritis, you can get some clue on the urine analysis itself, because the most common cause for interstitial nephritis is what? Drug allergies, mainly beta lactams. And whenever we talk about allergies, we talk about eosinophils. So if I have drug allergy, I will have increased eosinophils in the blood, and those eosinophils will also reflect in the urine. The normal urine analysis, barely you will see eosinophils, but if you see eosinophils in the urine, then you know that there is probably interstitial nephritis. So if there is eosinophil urea, it can happen in pyelonephritis, but most important thing you have to remember is interstitial nephritis. So history wise, if I have a patient who has been exposed to some drugs, after that he has developed a rash, allergic rash, and then the creatinine has gone up, and in the urine I get eosinophils, classical story of interstitial nephritis due to drug allergy. If someone presents with raised creatinine, has periorbital edema, proteinuria, smoky urine, cola-colored urine, hematuria, dysmorphic RBCs, classical case of glomerular injury, nephritic syndrome, right? Where the challenge lies is differentiating between the prerenal AKI, which may not come with any specific findings on the basic investigations, and patients developing acute tubular necrosis. And acute tubular necrosis need not only happen because of drugs. Prerenal AKI itself may progress to cause acute tubular necrosis, because if the blood flow to the renal tubules comes down, The tubules also need blood supply. The tubular epithelial cells needs blood to survive. So if they're not getting blood supply, they will get necrosed. So prerenal AKI, in fact, is one of the leading causes for acute tubular necrosis. So then how will I differentiate whether this patient has prerenal AKI or ATN, or it is prerenal AKI which has led to ATN? So many universities have often asked this question: how do you differentiate between prerenal AKI and acute tubular necrosis? So can anybody tell me what is the most important investigation that helps you to differentiate between prerenal AKI and acute tubular necrosis? Like, let us try to understand this on a logical ground. So we know that nephrons are the structural and functional unit of the kidney. Afferent arteriole brings the blood to the kidney, and that blood leaves through efferent arteriole, and the pressure drives for the filtration. Filtration happens into the Bowman space, and then blood passes through, the filtrate passes through PCT, loop of Henle, distal convoluted tube, finally collecting that's eventually excreted out as urine. So when you say prerenal AKI, we know that afferent arteriole, the blood flow is reduced for whatever reason, because of renal artery stenosis, hypovolemia, loss of renal autoregulation, whatever. Now, if the blood flow reduces, we are not able to counter it. So the amount of filtration is reduced. So the amount of blood filtered will be less. So because of that, you will have high creatinine, high urea, and other manifestations. Now let us talk about the filtrate that is coming out as urine. What will happen to the amount of urine that we will be excreting if the blood flow to the kidney is less? Less the blood flow, less the filtrate, less the urine output. So if you have prerenal AKI, you will have oliguria, decreased urine output. Okay, fair. Now you know how the physiology works. First, we create a filtrate called as glomerular filtrate by filtering the blood. This filtrate that we create contains whatever that comes in the glomerular Bowman space. It contains wanted and unwanted substances. Means there are some substances which are filtered but we want them back, and there are some substances which are filtered, we don't want them back, we want to excrete. So what are the wanted substances that get filtered? It includes glucose, it includes sodium, it includes amino acids, it includes bicarbonate. So these are the substances that our body needs, but it is unfortunately filtered, we need to get them back. And there are unwanted substances like creatinine, urea, H plus ions. We don't want to get them back, we want to kind of lose them in the urine. So once we have created the filtrate, what we call as glomerular filtrate is a mixture of substances that we want back and substances we don't want them back. So the substances that we want them back, they get reabsorbed as the filtrate passes through the tubules. Majority of the reabsorption, like glucose, amino acids, all of that happens at the level of proximal convoluted tubule, like SGLT2, which is facilitating the reabsorption of glucose, sodium. So your glucose, sodium, water, most part of it, amino acids, they get reabsorbed in PCT. Some part gets reabsorbed in other parts of the tubule. So can I say that filtration happens at the glomeruli and then reabsorption happens at the tubules? So if I have caused prerenal AKI, the filtration itself is impaired. So my creatinine, urea in the blood will be elevated because I'm not able to filter them out. Okay, now let us say prerenal AKI is not there. I've rather damaged the tubules. So in that case, the filtration process will run smoothly. But after that, when I try to reabsorb, that is where the problem is, right? So when I had prerenal AKI, I could not filter large amount of water. So the amount of water excreted will be less. I will have oliguria. But if I have acute tubular injury, I filter, but then tubules are damaged. So I fail to reabsorb because reabsorption happens at tubules, but they are damaged. So I fail to reabsorb. So I lose all of that water without sufficient reabsorption. So I may end up with polyuria. So tubular injury may present with polyuria. Prerenal AKI may present with oliguria. Both of them will have raised creatinine, but urine output is different. The second thing is, if I'm not able to reabsorb the substrates because of the tubular injury, I will start losing those substrates in the urine. Okay, so especially important thing is sodium. The sodium reabsorption happens at tubules. There are multiple channels involved, and if I have done the damage to the tubules, I will not be able to reabsorb sodium. So the amount of sodium that I'm losing in urine will be high, right? So in case of the tubular injury, we will have polyuria, large amount of water without being reabsorbed is getting lost, and also sodium is getting lost without being reabsorbed, right? Okay, now tell me what will happen to the sodium in patients with prerenal AKI. The blood flow to the kidney has come down, and kidney has counter regulatory mechanisms, so it wants to increase the blood flow. And at the same time, okay, also think about it. If the blood flow has come down, most commonly because of hypovolemia, that means your BP is also dropping because of hypovolemia. Don't you think body will have a counter mechanism to correct that hypovolemia? What is the mechanism? You have RAS. The RAS will come. In the RAS, we have angiotensin 2 and aldosterone. So angiotensin 2 will cause the efferent arterial constriction so that you can continue the filtration process. Second, the aldosterone, what it will do? Aldosterone will increase the reabsorption of sodium and water through epithelial sodium channel. So you start reabsorbing a lot of sodium and water. If the blood flow to kidney comes down, you start reabsorbing a lot of sodium and water. So the amount of water you lose in urine and the amount of sodium you lose in urine will be less. In case of acute tubular injury, you have caused the damage to the tubules, so you're not able to reabsorb sodium and water, so you lose water and sodium in urine, right? So this is a basic differentiating feature. So let us write down those findings. So if I have prerenal AKI and if I have acute tubular necrosis, so if you have prerenal AKI, very often you have oligouria. You might end up with polyuria if you have ATN because you're not able to reabsorb water. Second, when you have prerenal AKI, because of hypovolemia and hypotension, there is activation of RAS, and aldosterone is making you reabsorb most of the sodium and water. And because you're reabsorbing sodium, the amount of sodium excreted in the urine will be less. So you'll have low urine sodium. But in acute tubular necrosis, you're not able to reabsorb the water and sodium. So you will have increased urine sodium. But if you ask me what is the most important investigation that helps me to differentiate between prerenal AKI and acute tubular necrosis, we will call that investigation as FENa, which stands for fractional excretion of sodium. Okay. Without going into the formula, let us understand conceptually what is this FENa. So the amount of sodium presented to the nephron, out of it, how much percentage of sodium gets excreted. In case of prerenal AKI, aldosterone is activated, so we will absorb most, so we will not excrete much of the sodium. The percentage of sodium excreted is less. It will be generally less than 1%. But if the tubules are damaged, I am not able to reabsorb sodium. I excrete more sodium. So then the fractional excretion of sodium will be more than 2%. More than 2%. So this is the single most important investigation that helps you to confidently differentiate between prerenal AKI and acute tubular necrosis. Okay, clear? So this is what I want you to mention, particularly mention the fractional excretion of sodium, its role in differentiating between prerenal AKI and acute tubular necrosis. Also, the other things that can be additional clues is that prerenal AKI will have hyaline casts in the urine, but the acute tubular necrosis will have renal tubular epithelial cell casts and muddy brown casts. Okay, so that's about our acute kidney injury. Now let's progress to the next question. The next question is going to be CKD. So one of the questions that they might ask is define the CKD, mention the causes for CKD, discuss the complications of CKD and their management. It's a common standard template. Some universities might ask you to elaborate more specifically on one of the complications like hyperkalemia, its evaluation and management, or CKD related mineral bone disease, its evaluation and management, or uremia and its complications including uremic pericarditis. So we will delve deeper into some of the important complications. So first thing is, what is CKD? I know the full form is chronic kidney disease, but what is the technical definition? AKI, we learned the technical definition, right? Urine output less than 0.5 ml per kg per hour for 6 hours or higher, or creatinine jumping 0.3 milligrams per deciliter within 48 hours, or 1.5 times the baseline within 7 days. How do I define the CKD? CKD is defined as chronic renal dysfunction. But what do you mean by chronic? 10 days, 21 days, 1 month, 1 year. Chronic renal dysfunction characterized by eGFR, estimated GFR less than 60 ml per minute per 1.73 meter square body surface area for more than or equal to 3 months. If anybody's GFR is less than 60 ml consistently for at least 3 months, then you can call it a CKD. If it's like it drops for a week, 2 weeks, and then improves back above 60, then we will not call it as CKD. It happens many times. Like all these AKIs, GFR decreases, but once you recover from AKI, GFR bounces back. But if your GFR remains low, less than 60 ml per minute per 1.73 meter square body surface area for 3 months or higher, then you call it as CKD. Now, estimated GFR, how do we measure? So the eGFR, the preferred method currently for estimating the GFR is going to be CKD-EPI equation. We don't follow this Cockcroft-Gault formula per se in real practice because it has its own limitations, but this is the only formula that a medical student or a doctor can remember. All other formulas are complex. We can't remember, or we can't calculate with pen and paper. We literally need a scientific calculator. So they're all always calculated using the digital sources. But Cockcroft-Gault formula, often teachers ask you to mention that. So I'm just mentioning it here, which is an outdated method of estimating the GFR. So where it says patient's age is subtracted from 140, then multiplied by the lean body weight expressed in kilograms, divided by creatinine expressed in milligrams per deciliter into 72. That gives you the estimated GFR according to Cockcroft-Gault equation. Not a very good equation. Ideal equation is CKD-EPI equation. Okay. Now, what causes the GFR to go below 60 ml for 3 months or higher? What are the common causes for CKD? Well, when it comes to India, in fact, not just India, the rest of the world, the most common cause for low GFR or persistently low GFR, what we can call as CKD, is diabetic nephropathy. Diabetic nephropathy is the most common cause for CKD. How common it is? It accounts for more than 50 to 60% of cases. In fact, in India, it accounts for more than 2/3, means more than 66% of the cases of CKD that we see today are because of diabetes. And after that, the second most common cause is hypertensive nephropathy. Hypertensive nephropathy is the second most common cause. This also accounts for close to 20% of the cases. Means almost 80% of CKD patients are diseases of lifestyle. Either you end up with diabetes, hypertension, or a combination of both, and you end up with CKD. All your glomerular disorders, right? What drugs, chronic causes of renal injury because of drugs, like the long-term use of analgesics, what you call as analgesic nephropathy. All of them are quite rare, including lupus nephritis. All of these are quite rare. So other chronic glomerular disorders account for a very minuscule number of cases, like lupus nephritis, focal segmental glomerulonephritis, which can also be because of HIV, then drugs like analgesic nephropathy. These are all less common causes, right? So when it comes to the causes for CKD, I want you to mention 3 points. Most common is diabetic nephropathy. Second most common is hypertensive nephropathy, other chronic glomerular disorders, and tubulointerstitial disorders. These are relatively less common causes. Relatively less common causes. Okay. Now let us say someone developed the declining GFR sustaining for 3 months or higher. Now we know that it is CKD. How do I stage it? Because in common conversation, we often talk about it is the stage 1 CKD, stage 2 CKD. So what is the basis for staging? The basis for staging is it is based on estimated GFR and albuminuria. Because when glomerular damage, you will have proteinuria. So the degree of proteinuria and the drop in the GFR. These are the parameters used for staging of the CKD. So we will have two parameters here. One is estimated GFR, second is albuminuria, and patients of CKD may have both the decrease in GFR as well as protein loss, and both have to be quantified in staging. So whenever we talk about a stage of GFR, a stage of CKD, the stage is assigned with two numbers or two digits. One talking about what is the current GFR, second talking about what is the status of current proteinuria or albuminuria. Okay. So like let us say I have a patient with, in terms of GFR, this patient has G2 stage, and in terms of albuminuria, this patient may have A3 stage. So every patient's CKD is given this two digit numbering system, G and A. G stands for GFR, A stands for albuminuria, right? So first let us look at GFR. The normal GFR is 90 ml per minute per 1.73 meters square body surface area. So when it is 90 ml or higher, we will call it as stage G1. If it is 60 to 89, we will call it as G2. If it is 45 to like less than 60 up to 30, we will call it as G3. G3 is further divided into G3A and G3B. 30 to 60 is G3. Within that, 45 to 60 is G3A and 30 to 44 is G3B. And then less than 30 up to 15 is G4 and less than 15 is G5. And at the same time, you should also remember any patient on dialysis will always be considered as G5 because their GFR cannot be estimated. Artificially, we are dialyzing them. So any patient of AKI started on dialysis will be stage 3 AKI. Any patient of CKD started on dialysis will be G5, right? So you have to remember that. So this is in terms of the GFR. So when you said G2 stage, that means the GFR is somewhere between 60 to 89. Like let us say 70 is the GFR estimated according to the CKD-EPA equation, then I know it is G2 stage. Now let us also talk about albuminuria. Now if I am losing less than 30 milligrams of albumin per 24 hours, then it will be called as A1. If it is 30 to 300, it is A2. And if it is more than 300 milligrams, then it will be called as A3. Now this albuminuria can be either estimated by collecting 24-hour urine sample, which is cumbersome, or alternatively, you can calculate it something called as urine albumin creat ratio. You just take a single sample, calculate how much albumin is there and how much creatinine is there in the urine, and then express it as a ratio like urine albumin divided by urine creat. So for every 1 gram of creatinine lost in urine, how much albumin you are losing? That's what USAR stands for. You don't have to give too much of stress to your brain because the numbers are same. Whether you're expressing it as 24-hour urine albumin or you're expressing it as urine albumin creatinine ratio, the numbers are same. If it is less than 30, it is A1, 30 to 300, it is A2, more than 300 is A3. So in this case, when I said the albuminuria wise, the category is A3, we are referring to this patient having more than 300 milligrams of albumin loss per day in urine. So G2A3 stands for 60 to 89 GFR and more than 300 milligrams of albumin loss per day. Clear? So this is how we do the staging. You need to probably by heart this because this table you might have to recreate if they're asking specifically about the staging. Okay. After we're done with the staging of CKD, let us talk about the complications. What will happen if the kidneys become chronically dysfunctional and lose the GFR? So to understand the complications, all we need to know is to understand the functions of the kidney. So what are the basic functions? Volume regulation is one of the very, very important functions. I keep drinking a lot of water. The excess water has to be eliminated from the body. How do we eliminate? Kidneys, right? So there are various ways of regulating this volume content in the body. You have ADH, you have aldosterone. They are playing a role in regulating the volume. Apart from that, you have a thirst mechanism. But if kidneys are dysfunctional, I may not be able to excrete the excess water. So I will start retaining the fluid. So what complication it will lead to? Hypervolemia or fluid overload or fluid overload. And what complications the fluid overload can lead to? This fluid overload can lead to pleural effusion, generalized edema, it can also lead to ascites and pericardial effusion. And a more severe complication of this fluid overload is this may also contribute to, because there is increased volume burden on the heart, it may lead to heart failure. So all these problems are likely to be expected because of fluid overload. Now, how do I manage this? So this complication we understand. Okay, excess water is lost by kidney, and if kidneys are dysfunctional, I'm not able to lose the water. So we start retaining the water. And where do I keep that extra water that is building up in the body? All the third spaces, the pleural space, peritoneal space, pericardial space, subcutaneous space. I start depositing the water there. So I get this pleural effusion, pericardial effusion, ascites, generalized edema. And when the circulating blood volume is high, heart is doing more work, somewhere down the line it will fail. So heart failure. So these are the complications because of fluid overload. Now I, as a doctor, have to manage this. Patient kidney has failed, GFR is pretty low, he is developing fluid overload. How can I manage it? What all should I advise? How can I manage this? Crazy loser, creatinine levels calculated after 24 hours of staging in CKD. Well, creatinine is regularly monitored in patients with CKD, especially if we start them, like when to decide, to decide about when to start a dialysis, we constantly monitor their RFT. At the same time, if they're on dialysis, to assess the adequacy of dialysis, we need to monitor their renal function, including urea and creatinine regularly. Okay, so when it comes to management of fluid overload, how do I manage? The first thing is restrict the amount of fluids that they are drinking based on their output. So fluid restriction. And then we know that more the salt I take, aldosterone will make me reabsorb that salt, and with the salt, water will also be reabsorbed. So it will add to the burden. So I have to also restrict the salt. So fluid and salt restriction. What else I can do? I can use diuretics to flush out the excess water. And what diuretics are useful, especially in CKD patients? Thiazide diuretics are not sufficient, because thiazide diuretics are more ideal when you want a mild diuresis to reduce the BP. So as an antihypertensive, they're decent enough, but they're not good when you have volume overload. You need loop diuretics like furosemide. Okay. And then if despite the fluid restriction and diuretics, if they are refractory to the standard treatment, what do I do? The last resort is always dialysis. So I will dialyze and remove this excess water. But at least in the initial stages, I can try to manage this volume burden by giving diuretics, fluid restriction, and salt restriction. So that is one complication. The second complication of CKD that we're going to talk about is we keep loading a lot of potassium into our body, because the fruits, vegetables, and even the water contain ample amount of potassium. And we need to maintain this potassium level in a very tightly regulated range of 3.5 to 5.5 milliequivalents per liter. Anything higher will start affecting the cardiac function, and we may end up with arrhythmias and even cardiac arrest. So hyperkalemia is one of the dangerous complications of CKD. because elimination of this potassium is a function of kidney, and if they are dysfunctional, we are not able to eliminate. So what this hyperkalemia can lead to? It will lead to ECG changes and skeletal muscle weakness. So this patient can become paralyzed because of hyperkalemia. Even hypokalemia can cause. ECG changes wise, you will get a tall T waves and then prolonged QRS, and then there is formation of something called as sine wave, and eventually there is risk of ventricular tachycardia, ventricular fibrillation, and cardiac arrest. So these complications are expected if I have very high potassium, especially when it is more than 7.5. The chances of developing cardiac arrhythmias is high. So then if I encounter a patient with CKD whose potassium is going high, how do I manage it? So first thing is we have to restrict the potassium intake, dietary restriction of potassium. So fruits which are generally rich in potassium or any other source high in potassium, those should be avoided. All the patients of CKD get a pamphlet of food items listed to have high amount of potassium that they should eliminate from their diet. Dietary restriction of potassium. What else I can do? Well, whatever potassium, little potassium that comes through the diet after restricting the high potassium items, still diet will have some amount of potassium. Its absorption can also be restricted. How? I can give agents which will bind to the potassium. Like with the food, if I take these potassium binders, they will bind to the potassium and make them loose in the stool without getting absorbed. So we'll call them as potassium binding resin. Potassium binding resins. Example, kyaxalate. So that I can keep excreting potassium in the stool without absorbing in large quantities. But despite all these dietary restriction and potassium binding resins, if kidneys are so dysfunctional that even a tiny load of potassium coming to the body is making the blood potassium level go very high, then what I can do? Then your heart is at risk and you might have to go for what we call as anti-hyperkalemia measures. So what are these anti-hyperkalemia measures? First thing is protect the heart. How do I protect the heart? Because high potassium is going to cause the ECG changes and eventually lead to cardiac arrest and death. That can be protected by calcium gluconate. Calcium gluconate acts as a membrane stabilizing agent and it protects the heart from the impact of this high potassium. Calcium gluconate 1 gram per 10 ml slow IV. Okay, so now I have kind of protected the heart from developing arrhythmias, but then it is a transient protection. I need to bring down the potassium levels. How can I bring down the potassium levels? I can give insulin, usually with dextrose. Main thing here is insulin. Dextrose is not the main drug. Insulin is the main drug. What insulin will do? Insulin shifts the potassium from extracellular compartment, means blood. From the blood, insulin shifts the potassium into the cells. So the amount of potassium in the blood comes down. Now I have more potassium in the cells, which will not cause any impact on the heart because all the potassium is inside your tissue cells. But because insulin, while doing so, will also shift the glucose into the cells and the blood glucose level can drop. So to counter that, I also have to add dextrose. So we'll give insulin with dextrose. Similarly, I can also achieve that with salbutamol. Salbutamol also facilitates shifting of potassium from extracellular compartment to intracellular compartment. So these measures will bring down the potassium values. But the problem is, okay, this time patient came to me, potassium was high. I gave the calcium gluconate to protect the heart, gave insulin and salbutamol neb, and that brought down the potassium. But this patient's kidneys are dysfunctional. He goes home, he takes some potassium containing food, it will shoot up again. So the patients who have hyperkalemia, which is refractory to anti-hyperkalemia measures, in them what is the solution? They are not responding to anti-hyperkalemia measures. Then again same thing, dialyze, the dialysis machine will flush out the potassium. Dialysis is the treatment to go for patients who are refractory to anti-hyperkalemia measures, right? So that is the second complication, hyperkalemia. So fluid overload was the first complication we addressed. Then hyperkalemia is the second complication. Okay. What other complications the CKD can lead to? The third complication that CKD can lead to, we will call it as CKD related mineral bone disease. What do I mean by that? The bones get impacted in CKD. Two things can happen. Either bone turnover increases because of increased osteoclastic activity and the bones become fragile, or bone turnover decreases, gets suppressed. In that case, we will call it as adynamic bone disease. So high bone turnover as well as low bone turnover both can happen. And let us try to understand the pathophysiology, exactly why it happens. The root cause of why the bone gets affected is not calcium, abnormalities in the calcium. The main root cause is change in the phosphate, because phosphate excretion, excess phosphate that comes into our body, its excretion is a function of kidneys. But if kidneys are dysfunctional, we start retaining the phosphate. So we will have increased phosphate values, right? What you call as hyperphosphatemia. Hyperphosphatemia. And the hyperphosphatemia is a potent stimulus for increase in parathormone. PTH levels increase in response to hyperphosphatemia. Another thing happens in CKD. What is that? In CKD, the blood calcium level also comes down. Can anybody tell me why we have low calcium in CKD? Parathormone is not rising only because of hyperphosphatemia, though it is the main factor. It's not hypocalcemia, but hypocalcemia also happens. Now remember, kidneys produce an enzyme called as 1-alpha hydroxylase. 1-alpha hydroxylase, which converts 25 dihydroxycholecalciferol or calcidiol to 125 dihydroxycholecalciferol or calcitriol. So calcitriol is the active form of vitamin D, as we know. This is the active form of vitamin D. So calcidiol is relatively less active, calcitriol is more active, and that conversion of less active form of vitamin D to more active form is done by 1-alpha hydroxylase, which is produced by kidneys. So kidneys are the ones which are producing it. But if kidneys are dysfunctional, then the amount of 1-alpha hydroxylase expressed by kidneys is less. So you have less amount of active form of vitamin D. So CKD leads to decreased active vitamin D. CKD leads to decreased active form of vitamin D. Right. The reason for that is due to deficiency of 1-alpha hydroxylase, which is produced by kidney. And vitamin D is required for the absorption of calcium in the GIT. So if I have less vitamin D, then I may not be able to absorb the sufficient quantity of vitamin D, even if I'm eating sufficient calcium, even if I'm eating sufficient calcium in my diet. So there will be decreased GI absorption of calcium. And because of that, I may end up with hypocalcemia. So this hypocalcemia is also contributing to the increase in parathormone, right? We will call it as secondary hyperparathyroidism. Now, because of this hyperparathyroidism, there will be, because parathormone, what does it do? It goes to the parathormone wants to increase the blood calcium level. How will it increase? It will go to the bones, break down the bone by increasing the osteoclastic activity, or in other words, increase the bone turnover, bring the calcium out so that this hypocalcemia gets corrected. So this increased parathormone will increase bone turnover by increasing osteoclastic activity. And because of that, now what happened? Bone is losing the calcium. So this will try to counter the hypocalcemia, but bone is losing the calcium. It is becoming osteomalacic, and eventually you may develop what you call as the brown tumors. So this is one of the complications that we can expect. It is high bone turnover disease. Now let us say I got a patient of CKD and I don't want his bone turnover to increase and his bones to lose calcium. So what will I do as a doctor? One thing I can do is I can try to restrict the phosphate intake, because CKD is the reason. But if I restrict the phosphate intake, then this hyperparathyroidism can be countered to some extent. Second thing, these patients have deficiency of active form of vitamin D. So I will give them active form of vitamin D. And they have low calcium in the blood. So I will give them calcium supplementation. That's how we treat. We restrict the phosphate. We try to keep the phosphate levels low. And we supplement with vitamin D and calcium. All of these things put together, they can counter the hyperparathyroidism and thus counter the increased bone turnover that is happening. But then the problem is, what if I do this over enthusiastically? What if I bring down the phosphate levels to less than normal? And what if I increase the calcium to more than normal? In that case, what will happen? There will be suppression of parathyroid hormone production, right? So we'll now have hypoparathyroidism. And because of that, the bone turnover comes down to less than normal. So the bone activity is low. And because of that, we end up with, like, even if I have a trauma, there is no sufficient activity inside the bone to heal it. So we'll call that as adynamic bone disease. So the main problem that CKD leads to is high bone turnover, but the over enthusiastic treatment by the doctors can lead to adynamic bone disease. It's like treating diabetes. You have high glucose, so you give insulin to bring it down. But if you give over enthusiastically higher doses, you cause hypoglycemia, right? Same thing is happening here. So CKD related mineral bone disease. CKD related mineral bone disease is of two types. One is high turnover. The other one is decreased bone turnover. When there is high bone turnover, you may end up with development of what we call as brown tumors, areas with increased osteoclastic activity, or decreased bone turnover causes what is called as adynamic bone disease. Adynamic bone disease patients generally develop frequent fractures which do not heal easily, because for healing you need to have the bone turnover happening. Okay. So high bone turnover is due to hyperparathyroidism, CKD induced hyperparathyroidism, and decreased bone turnover is due to hypoparathyroidism, which is happening because of treatment. So you can even label it as iatrogenic hypoparathyroidism. Okay, so that's about the CKD related mineral bone disease. Now, how do I manage the high bone turnover, which is more common? I have to do a phosphate restriction in the diet. So the dietary items which are high in phosphate, they should be eliminated. We can give phosphate binders. Example of phosphate binder that I can quote is sevelamer, which is a phosphate binder. You might have seen a lot of CKD patients in your wards getting this sevelamer along with meal, so that in the meal whatever phosphate is there is bound by the sevelamer and takes it away in the stool and doesn't get absorbed. Then calcium and vitamin D supplementation. Rishank, you can definitely drop the doubt here. I will address it. Sutapa Samantha, in AKI also we need the dialysis. I mean, we might require. So most of the case of AKI, the treatment primarily depends on treating the underlying cause. But when underlying cause cannot be treated, or if they are developing any of the complications related to kidney dysfunction, like if hyperkalemia happens even in patients with AKI and it is causing ECG changes, cardiac dysfunction, we have to go for dialysis. Okay, we will discuss a little bit about the dialysis later. Okay, then what else I can do to treat this high bone turnover? What can I do to treat this apart from restricting phosphate and supplementing with vitamin D and calcium? See, the root causes high phosphate, but the pathology is driven by hyperparathyroidism. What if I give a drug? See, hypocalcemia is also stimulating it, right? But what if I give a drug which tells the parathyroid gland that calcium level in the blood is normal? Though it is low, it signals the parathyroid gland to believe that the calcium levels in the blood is normal. In that case, the parathyroid gland will reduce the parathormone production, the bone turnover will decrease, and the problem is offset. See, adynamic bone disease, basically in your bone, there's always some degree of bone breakdown and some degree of bone formation happening. Osteoblasts and osteoclasts are active. So there is constantly, like, the cells are dying and they're rebuilding. So there is constant process going on. Adynamic bone disease refers to halting the bone breakdown as well as bone formation. So no activity at all. So when I cause a fracture, because there is no turnover happening, no activity happening, you can't build that back. The fracture will stay. That's what we call as adynamic bone disease. So even minor traumas are not well tolerated in patients with adynamic bone disease. In patients with high bone turnover, osteoclastic activity is increased. So the rate of bone breakdown is more than the rate of bone formation. So because of that, see, the amount of bone matrix formed and the amount of bone matrix dissolved, the amount of bone matrix dissolved is more. So that's why the bone starts shrinking. So we are losing the calcium from the bone. And that's what we're trying to counter here in the management that we're talking about. So we have something called as calcium sensing receptor mimetics. What are these? You know, in the thyroid gland, we have these, on the thyroid gland, we have these parathyroid glands. Parathyroid glands get to know whether blood calcium level is normal or not based on a receptor called as CASR. So if I stimulate this receptor, then the parathyroid gland feels that, okay, there is sufficient calcium in the blood. Now, ideally, calcium stimulates this receptor so that parathyroid gland get to know that sufficient calcium is there. I don't have to release the parathormone. I can also create drugs that can mimic like the calcium and stimulate this receptor. So parathyroid gland gets tricked to believe that there is sufficient calcium in the blood. So I don't have to release the parathormone. So parathormone levels comes down and the bone turnover gets normalized. And example for that is cinacalcet, etacalcide, cinacalcet. These are all calcium sensing receptor mimetics. Now, how am I going to manage this adynamic bone disease? We have to relax. See, it is over enthusiastic treatment of high bone turnover has resulted in adynamic bone disease. Like someone gets hypoglycemia, what do I do when I'm treating them with insulin? I reduce the insulin dose so that they don't get into hypoglycemic episode. So same here. So relax the amount of phosphate restriction that we are putting the patient on, and then decrease or stop vitamin D and calcium supplementation that you are giving, so that the minor degree of hypocalcemia that comes in, the phosphate level that increases, will increase the parathormone level and the bone turnover will improve. That's how we will treat the adynamic bone disease. So it's like exactly opposite. The two treatments are exactly opposite because the two disease processes are exactly opposite. Okay, so that's about our third complication. So what other complications we are expecting in CKD? The fourth complication that we expect in CKD is development of metabolic acidosis, because kidneys play a very important role in the acid base regulation, mainly excretion of H plus, which is the proton or the main acid in the body. and reabsorption of bicarbonate, which is the main base. So when kidneys become dysfunctional, I'm struggling to excrete the acid, I'm struggling to reabsorb the base. The end result is development of metabolic acidosis. And the metabolic acidosis, it has its own complications. So what it will lead to? It is due to impaired H plus excretion and bicarbonate reabsorption. Okay, so now what problems the metabolic acidosis will lead to? So metabolic acidosis will have metabolic acidosis. The acidic pH is not good for a lot of biochemical reactions that happen at the cellular level, mitochondrial level. So because of that, the cellular metabolism gets affected. So you'll have decreased cellular metabolism, because all these biochemical processes like Krebs cycle, all that you study in biochemistry, all those reactions function perfectly well in the normal pH range of 7.35 to 7.45. Higher than this or lower than this, these biochemical processes don't run normally. So you'll have decreased cellular metabolism, and this decreased cellular metabolism often result in myocardial depression, because heart cells also have constant metabolism going on. And because of this myocardial depression, means the cellular activity of myocardial cells decreases. That will result in decreased cardiac output and hypotension. So many patients with severe metabolic acidosis eventually get into shock because of the decreased cardiac output and hypotension. And all of this is happening because acidic pH is a myocardial suppressant. Okay, what else the metabolic acidosis does? Metabolic acidosis stimulates the respiratory center, because there has to be a respiratory counter for the metabolic acidosis, right? So it stimulates the respiratory center. Where is the respiratory center present? Medulla oblongata. Respiratory center. And once the respiratory center gets stimulated, there will be hyperventilation. Hyperventilation, and we call this as acidotic breathing or Kussmaul's breathing, or Kussmaul's breathing. So can severe metabolic acidosis be the reason for death? Well, if it is suppressing the myocardial activity to the point where you end up with shock, it can lead to death. Now, how am I going to manage this metabolic acidosis? So the first thing when it comes to the management of acidosis, you can see, why am I getting acidosis? On one side, I'm not able to excrete H+. I can't do much about it. The other side, I'm not able to reabsorb bicarbonate. Something I can do. I can give the bicarbonate orally or in the injectable forms so that I can build the base. So if the acid is increasing, to get the pH normalized, I have to increase the base. So I can supplement the base. So sodium bicarbonate supplementation, what you call a soda bicarb in your words. Sodium bicarbonate supplementation can be considered. But how long it will work? So if eventually sodium bicarbonate supplementation is not able to correct the pH, and you're seeing the consequence of metabolic acidosis, patient having this acidotic breathing or BP dropping down, you don't have a choice. If patient is refractory to soda bicarb, then you have to go for dialysis again. Okay, I'll address that. Okay, so it will lead to refractory to soda bicarb. Okay, so now that we have understood another important complication, now let's go to the one of the complication which is very, very difficult to manage conservatively. Like if I talk about the fluid overload, isn't it very challenging? It's not very challenging to manage. At least initial stages, restrict the fluid intake, restrict the salt and give diuretics. At least few months to few years, you may be able to pull without dialysis. If I have hyperkalemia, but if I have let us say mild hyperkalemia, I can manage it with the dietary restriction of potassium and potassium binding resins. If required, maybe other anti-hyperkalemia measures. If I have CKD related mineral bone disease, I can manage them conservatively without dialysis, right? I have to either give you calcium, vitamin D supplementation and phosphate restriction. And if I end up with a dynamic bone disease, reduce the restrictions that I am putting. If I end up with metabolic acidosis, at least for some time I can try to manage with the soda bicarbonate. But if I develop high urea, we will call it as uremia. High urea itself leads to a lot of complications, and it is not possible to manage the uremic complications without dialysis because there's no way to bring down the urea levels. Okay, but why is the urea problem? So please remember, urea is an osmotically active substance. So if this is my blood vessel and in the blood the urea levels increase, urea is an osmotically active substance. So the rule of osmosis says fluid moves from hypoosmolar to hyperosmolar compartment. So in the blood now I have urea, so the osmolality of blood is high. The cells, the osmolality is less. So from the cells, the water will move to the blood. So the cells will lose the water and they start becoming dehydrated. So the cellular dehydration leads to various complications. And which cell is most vulnerable? It is the neurons. So when the urea level starts increasing, we are literally squeezing the water out from the neurons into blood. So neurons are getting dehydrated and the dehydrated neurons start becoming dysfunctional or even lead to neuronal death. And once the neurons are dehydrated, dysfunctional, I start developing CNS complications, and we'll call the condition as uremic encephalopathy. Uremic encephalopathy. Okay. Second, what are the complications we can lead? The high urea levels are also not tolerated well by, because the serum osmolality is increasing, and there is something called as chemoreceptor trigger zone, which is constantly monitoring the composition of the blood, the chemical nature of the blood. And if the urea levels are getting high, the chemoreceptor trigger zone gets activated, and the main function of chemoreceptor trigger zone is to induce nausea and vomiting. So these patients have very severe nausea and vomiting. Then the other thing that I can expect is, just like how dehydration of neurons is happening, I can also cause osmotic injury or dehydration of the cells of the pericardium, and that can lead to pericarditis. We will call it as uremic pericarditis. Okay. Then high urea also causes the damage to RBCs. Like in pathology, Ranjit might have told you the disfigured RBCs that you get in uremia. So you will have damage to the RBCs resulting in hemolysis. Uremia, high urea also becomes the toxin to the platelet. So it can also cause platelet dysfunction. So because of the platelet dysfunction, there is increased bleeding risk. So all these are complications. And uremic encephalopathy, also remember that they present with something called as asterixis or flapping tremor or flapping tremor. Now all these complications, many of them are life-threatening. What are life-threatening? Uremic encephalopathy can literally lead to obtundation, coma, and death. Uremic pericarditis can also be life-threatening, especially combined with the platelet dysfunction. So on one side, your pericardium are inflamed and you have platelet dysfunction. So you may start bleeding into the pericardial space, end up with cardiac tamponade and die. The nausea vomiting can be so severe that many of these patients get nutritionally deprived because they have aversion to eating food. They know that whatever small quantity of food I ate, it will trigger severe nausea vomiting. I'll puke, get tired. So they start avoiding food. They can develop severe life-threatening nutritional deficiencies. Hemolysis can also be a complication which may contribute to the risk of death. So uremia is one dreaded complication of CKD. But unfortunately, there is no way I can bring down the urea. There is nothing called urea binders because urea is produced inside the body. It is not mainly coming from outside. So like potassium binders, phosphate binders, no, there is nothing called urea binders. There are no chemicals, drugs, or injections to reduce the urea. So when you develop uremic complications, the only management that we can offer to these patients is dialysis. Dialysis is the only management for uremic complications. So any CKD patient who is having severe nausea, vomiting, and the other causes like gastritis or some food poisoning, they are ruled out, then you have to go for dialysis. Any patient with uremic encephalopathy, uremic pericarditis, uremic hemolysis, you have to go for dialysis. There is no other way. So uremic complications are considered as an absolute indication for dialysis. All other complications are not absolute. Potassium, you have anti-hyperkalemia measures. Only when they fail, you go for dialysis. Fluid overload, you have diuretics, salt and fluid restriction. When they fail, you go for dialysis. So dialysis, all other complications we studied are relative indications, but uremic complications are absolute indications, right? Now let us talk about one last complication of the CKD. So what is this? Anemia of CKD. Now many universities are asking anemia of CKD as a major component of CKD question. It's like define CKD, enumerate the causes for CKD, list the important complications of CKD, write a brief on the mechanism and diagnosis and management of anemia of CKD. So why we develop anemia in CKD? So let us understand the pathophysiology. Traditionally speaking, when we say anemia of CKD, it is primarily a normocytic normochromic anemia, but the reality is not. Okay, so what exactly happens in CKD is the erythropoietin production. So when you have CKD, kidneys are the ones which are producing the erythropoietin, and just give me 1 second. Kidneys are the ones which are producing erythropoietin, and if the kidneys are dysfunctional, there will be impaired erythropoietin production. Just give me 1 second, please. Impaired erythropoietin production, and this is the main mechanism. So if any teacher asks you in viva OSCE why you get anemia in CKD, just tell me one important reason, then it's going to be decreased erythropoietin production. And once there is erythropoietin production, there will be decreased hemoglobin and decreased RBC production. And this anemia is supposed to be normocytic normochromic. But then CKD will also have uremia. Uremia will have impaired, because uremia causes nausea, vomiting. These people will have aversion to food, and because so once there is decrease in when there is nausea and vomiting, you will have decreased food intake, or you can say there is aversion to food, and this decreased food intake or aversion to food will lead to iron deficiency. So iron deficiency is so common in patients with CKD that almost whatever patients of CKD I have seen, all of them had iron deficiency. So it's not just pure decreased RBC production and hemoglobin production because of erythropoietin deficiency. Iron deficiency is a major contributor. Now, if they ask you what is main, this is what you will answer, but you should also keep in mind that there is iron deficiency. Second thing, CKD itself is an inflammatory state. So there is systemic inflammation, and because of the inflammation, there is increased production of inflammatory cytokines like interleukin 1 and interleukin 6. And these inflammatory cytokines suppress bone marrow. So anemia of CKD, you can say it is multifactorial. It is not just because of erythropoietin deficiency. So all of them are coming together. But when it comes to treatment, what all I can do to help the patient? I can correct this iron deficiency. Probably I can't do much about the systemic inflammation that happens as part of CKD, but this iron deficiency can be corrected and erythropoietin can be supplemented, right? So then tell me now, how are we going to manage the anemia of CKD? How do you manage anemia of CKD? So first step is not to give erythropoietin, because if I give erythropoietin, what will happen? What will happen? So first step is not to give erythropoietin, because if iron deficiency is there and I give erythropoietin, erythropoietin will try to stimulate, but raw material to form hemoglobin is not there. So first step is correct iron deficiency. And because most patients of anemia in CKD, they may not tolerate the oral form of iron well, because they already have uremia, so they will have nausea, vomiting, and you give them iron supplementation, you will worsen their nausea, vomiting, and you will literally make their life hell. Majority of them will require parenteral iron therapy. So first step is correct iron deficiency. Second step is to start erythropoietin or a more synthetic derivative called darbepoetin. Darbepoetin is now preferred because of its long action. So you don't have to do multiple administration. So darbepoetin can require less frequent administration. So darbepoetin is preferred. So this is how we are going to manage the anemia of CKD, right? So before we close down the complication, let us talk about the management of CKD as a whole. So what I can do when I have diagnosed someone as having CKD. So first thing is treat underlying cause. If it is diabetes or hypertension, control the sugar, BP. That's one thing you need to do. Second thing is to decrease proteinuria. Now these patients have albuminuria, right? So how do I decrease it? How can I decrease the proteinuria? I can decrease the proteinuria by giving ACE inhibitors or ARBs. Now, can anybody tell me what are the precautions I should take in a patient with CKD when I'm starting them on ACE inhibitors or ARBs? Okay, so Tapasi, the urea is an osmotically active substance, and whenever the chemical composition of the blood gets altered, like if you take some antibiotics or if you take some cancer chemotherapy drugs, patients have severe nausea, vomiting, right? You know why that happens? Because the blood levels of those drugs start going up, and in the brain there is a area called as chemoreceptor trigger zone, which is a circumventricular organ, means there is no blood brain barrier. So when the blood chemical composition changes, that chemoreceptor trigger zone or CTZ senses it. And the chemoreceptor trigger zone, okay, basically believes that evolutionally, it believes that if there is some chemical coming into the blood, which is toxin, then it is mostly coming from GIT. That's how our evolutionally or developmentally humans are designed. Because IV, all of this has come recently, right? Otherwise, for millions of years, if some toxin enters human body, it enters through food. So if some chemical is detected in the blood, which chemoreceptor trigger zone thinks is not good, then it thinks that it is coming from GIT. So whatever is there in the stomach should be thrown out. That's how the chemoreceptor trigger zone is designed. So if I take some chemotherapeutic agent, its blood levels start increasing, chemoreceptor trigger zone senses it, it sends the signals to vomit it out. So similarly, when urea levels increase, the chemoreceptor trigger zone senses it and it activates the vomiting process. That's why we start vomiting. Okay. The second thing is how does it cause pericarditis, right? So urea is a osmotically active substance. So, and as I've already told you, if high amount of urea is there in the blood osmolality is high in comparison to cell. So water from the cells will be extracted to blood. So from the cells, the water starts moving to the blood. So because of that, the cells start shrinking, they become dehydrated. And when they don't have sufficient water molecules inside the cell, cellular metabolism gets affected. So cells become dysfunctional. And the dysfunctional cells activate the inflammatory cascade, and we will have the inflammation of those tissues which are dehydrated. And that's how we end up with pericarditis. That's how we end up with uremic encephalopathy. Okay. Rishabh, what's the query? Okay, just drop down. I think in the flow of comments, I missed your query. I will address it. Okay. So when it comes to management of CKD, we have to treat the underlying cause. Proteinuria can be treated by giving AC inhibitors or ARBs, but we have to have one caution. What is that? AC inhibitors or ARBs can worsen hyperkalemia. So if you have significant hyperkalemia, you might have to stop AC inhibitors or ARBs if you have started. Okay. Then third, management of complications. So individual complications we have already discussed. How do we manage anemia? How do we manage CKD related mineral bone disease? How do we manage uh, acidosis? How do we manage fluid overload? All of that we have discussed, right? Apart from that, what else I can do for these patients? The fourth one is renal replacement therapy. Renal replacement therapy means kidneys are dysfunctional, replace it. How do I replace? Either through the process of dialysis where machine is doing the job of kidney, or give the patient a fresh kidney. So it could be either through renal transplantation or dialysis. Uh, Crazy loser, I'm not able to understand what you're talking about. Anuria. See, muddy brown casts are nothing but renal tubular epithelial cell casts, Sudhapa. So this is, let us say, this is a tomorsol protein sheet that is precipitated in the tubules. Now, if I have acute tubular necrosis, the tubular cells are dead, so they will all be shed, and those cells will come and get attached to this cast, and it becomes what we call as renal tubular epithelial cell cast, RTEC cast. Now these cells will go into apoptosis because the cells are shed there, and the cells will die, they will disintegrate. Cells will not remain same like that, right? So as they start disintegrating, there is release of pigments like lipofuscin, which makes this cast brownish, the cells brownish, and this now whole cast appears like brown. It looks like this brown mud that we see. That's why it is called as muddy brown cast. So it is nothing but a renal tubular epithelial cell cast which is caught by the microscope little late. If it is fresh, it appears as renal tubular epithelial cell cast, but if cells have started disintegrating, it appears as muddy brown cast. Okay. Now, with respect to dialysis, what all types of dialysis we have? What all types of dialysis we have? Can anybody comment and tell me? Yeah, tell me what are the types of dialysis we have. So one of them is called as hemodialysis. The other one will be called as peritoneal dialysis or CAPD, continuous ambulatory peritoneal dialysis. Now, can anybody tell me which is more efficient in clearing the urea and creatinine? Which is more efficient in clearing the urea and creatinine? Is it hemodialysis or peritoneal dialysis? Okay, so remember, hemodialysis is more efficient in urea and creat clearance. So that's why when we see dialysis happening today, majority of the patients undergo hemodialysis rather than peritoneal dialysis. There are patients undergoing peritoneal dialysis, but as doctors, we would prefer to subject them to hemodialysis. Now, I have one last question. Between transplantation and dialysis, what is the best treatment? What is better for the patient? Should they go for transplantation or should they go for dialysis? So the fact of the matter is that dialysis is still not the perfect alternative to normal human kidney. So dialysis has its own set of complications. What are the complications? Kidneys filter a lot of unwanted substances, not just urea and creatinine. There are something called as middle molecules, right? One of such middle molecule is beta 2 microglobulin. There are a lot of them. I'm just listing one of them. This we want to lose from the body. It has to be eliminated. So when the normal kidney does, it filters urea, creatinine, phosphate, potassium, also middle molecules, including beta 2 microglobulin. And whatever dialysis machines we have today, they can clear the creatinine good, they can clear the urea well, they can clear the potassium well, but the handling of middle molecules like beta 2 microglobulin is poor. So we will not be able to eliminate them. So they remain in the blood. And when the blood levels of these middle molecules, particularly beta 2 microglobulin, increases, they start getting deposited in the tissues. And the deposition of beta 2 microglobulin in the tissues can cause amyloidosis. So dialysis is not a perfect alternative to kidney. It is the next best thing to kidney, but not perfect alternative to kidney. So if anybody asks you what is the best treatment for a patient with CKD, it is kidney transplantation, not the dialysis. Dialysis is the next best thing. Why am I stressing about it? Because when I was a medical student, there was a famous film star who did some show called Satyameva Jayate, and I think he was talking about doctors unnecessarily pushing the patients for transplantation for the sake of money instead of letting them just live with dialysis. And he invited some guests, some examples of someone living 10 years with dialysis, someone living 15 years with dialysis. I'm not denying that you don't live years with dialysis. Well, you can live, but your quality of life is not going to be as good as someone who has undergone renal transplantation. You might have seen patients with CKD who are living with dialysis. So number one, you might see that their skin is pigmented. Overall, their appearance is not very aesthetic. Their muscle mass is lost. All those issues. Apart from that, frequent visits to hospital for dialysis, inadequate dialysis leading to problems, and then again going for extra sessions of dialysis. During dialysis, dialyzer reactions, hypotension, all of these complications. So their life is full of ups and downs. So if someone gets a renal transplantation, well, I do agree that they need to be on immunosuppressants, but still their quality of life will be better. So the best treatment or the definitive treatment for a patient with CKD is going to be renal transplantation. Just because people can live years with dialysis doesn't mean that their quality of life is good. Okay, that is clear. Okay, so this is about the management of CKD. Now we will just add one small table for indications for dialysis, and with that we will end our discussion on CKD. Okay, so basically in dialysis what we do is we're trying to recreate the function of kidney. How kidney works: blood comes to the glomeruli, and then through a filtration barrier, the process of filtration happens, right? So we filter all small molecular weight substances, keeping cells and large molecular weight substances back in the blood. And from the filtrate, we reabsorb the substances that we want back, and we will lose the substances that we don't want in the urine. That's how kidney works. So in dialysis, what we do is, let me tell you first about the hemodialysis. So in hemodialysis, we make the blood enter into a chamber called as dialysis chamber or dialyzer. In this dialyzer, there will be an entry and a exit point, and there will be a membrane inside separating two sections of this chamber. So blood enters the dialyzer machine. Now this blood has high amount of urea, creatinine, potassium, and there is a membrane. On the other side of the membrane, there is a fluid which is called as the dialyzer fluid or dialysate. We will call this fluid as dialysate. Now this dialysate fluid generally contains no urea or creatinine, and it contains a very low amount of potassium. And this membrane that we have, this membrane is a semi-permeable membrane. It allows the diffusion of small molecular weight substances. Now urea concentration is high in the blood, less in the dialysate. So what will happen as the blood passes through it, urea will diffuse into this dialysate. Creatinine will diffuse into this dialysate. potassium will diffuse into this dialysate. So now the blood that is coming out of this chamber has lost urea, has lost potassium, has lost creatinine. So now this blood is filtered. So this blood will be returned back to the patient's body. And all this urea, creat and potassium that accumulates in this dialysate fluid, we will drain that out. We will discard it. This is how the hemodialysis works. Now the peritoneal dialysis also works on the same principle. But what we do in peritoneal dialysis is we use the peritoneum itself as the membrane. Means the dialysate fluid will be added into patient's peritoneal cavity. And the peritoneum itself will act as a membrane, and all the potassium from our potassium, urea, creatinine and other metabolic waste substances from our blood will diffuse into that dialysate fluid which we have added into the peritoneal cavity. After it has spent sufficient time in the peritoneal cavity, it has extracted urea, creatinine, potassium, we will open and discard that fluid. So we are using the patient's peritoneal cavity and peritoneum for the dialysis. That's the main difference. Okay. But when it comes to the hemodialysis, we have a lot of controls available. I can control the concentration of potassium in this blood. Like let us say I have a patient with CKD and I put him on potassium restriction, and because of that his potassium level has gone less than normal. He is now hypokalemic. And this patient's urea creatinine is still high. So he will still require dialysis. So in that case, I can use a dialysate which has higher amount of potassium. In fact, I can even make potassium, if the concentration of potassium is high in the dialysate, it can move into the blood as well. So I have a lot more control when it comes to hemodialysis. That's why hemodialysis is preferred, and it is more efficient because the peritoneal surface, how much ever it is, that much is the surface available for dialysis, right? The dialysis machine has large surface area available for the diffusion of substances. So it is more efficient. So hemodialysis is more efficient and a preferred mode today. Ghost stab, yes, the toxins and waste will cross. So this is a semi-permeable membrane. It's not a totally permeable membrane. So large substances, large molecular weight substances like albumin, globulin, RBCs, WBCs, they will not cross this membrane. So in the dialysis, we are not losing RBCs, we are not losing WBCs, we are not losing protein, we are only losing urea, creatinine, potassium, small molecular weight substances. And the same machine can also be used for dialyzing toxins. There are a lot of drugs which are dialyzable, which can pass through this membrane. So if someone has consumed those drugs in toxic doses, we can remove them through dialysis as well, right? So now coming to the indications, why or when we need to do dialysis. So the indications for dialysis, we will talk about them under two headings. The relative indications, where you can try to manage them with other modes, and absolute, where you don't have a choice. So what are the relative indications? Relative indications are fluid overload, when you are not able to manage fluid overload with diuretics. Hyperkalemia, when you are not able to manage it with anti-hyperkalemia measures. Then metabolic acidosis, when you are not able to manage with soda bicarb. But uremic complications like pericarditis, uremic encephalopathy, severe nausea, vomiting, they cannot be managed with conservative modes at all. So it's an absolute indication for dialysis. Okay, so AC inhibitors decrease the intraglomerular pressure. So if more pressure in the glomeruli, then more protein will be, because the pressure increases, more protein will be lost through injured glomeruli. So by decreasing the intraglomerular hypertension, because AC inhibitors will reduce the efferent arterial constriction. So intraglomerular pressure will come down. So the protein filtration comes down. Okay. Then flapping tremor. So flapping tremor is a form of negative myoclonus. A tremor is a abnormal movement disorder where patient will have same movement altering again and again. Like you get in Parkinson disease, they keep doing this movement. It is called as pill rolling tremor. So they keep doing the same movement again and again, again and again. They're constantly doing this. It's called as pill rolling tremor. So similarly, when you ask someone to outstretch their hands like this and hold the wrist in extension, not in a flex position, in extension, the patient may not be able to hold that position. The wrist drops. Then again, they get back to the extension position, it drops again. So they keep constantly doing this. This is what we call as, it looks like the flapping of the wings of a bird. That's why it's called as flapping tremor or asterixis. Okay, it's not specific to high urea. Any metabolic disorder that affects the brain function, we can get it. So we can get it in high urea. We can also get it in high ammonia. When liver becomes dysfunctional, you will have high ammonia. So then it's called as hepatic encephalopathy. Even when high carbon dioxide in the blood because of a respiratory problem, you can have that. Okay. What else I have missed? Why the GFR decreases if there is ATN? So it is because of the tubuloglomerular feedback. So as I told you, when there is tubular injury, we start losing sodium in urine. So the sodium reabsorption gets reduced. And because of that, the macular delta senses that there is probably high GFR. And now the tubuloglomerular feedback will activate reduction in GFR. How? By causing the afferent arteriolar constriction, so that the filtration gets reduced. So that is how we end up with decrease in GFR. Okay. Yeah, so this is the mechanism for the glomerular dysfunction when we have a acute tubular necrosis. Okay, so see, for the CKD as well as acute kidney injury, we are definitely looking at the GFR is calculated with the help of creatinine. So we need to know the blood creatinine values to get the estimated GFR. Without that, it's not possible. The main thing is the duration. So when you look at the definition, the AKI and CKD, it's about duration. So when we say AKI and creatinine is high, it invariably means the GFR will be low. Without the low GFR, your creatinine does not increase. So only when you're not able to filter, your blood creatinine level is increasing. So it means you have low GFR. Okay, you have low GFR even in AKI. So the real differentiator is the duration. So if your kidney functions are abnormal for a very short period of time, like as defined here, 48 hours or 7 days, then it is AKI. But if you have low GFR for a very long period of time, that is 3 months or higher, then we call it as CKD. Now, once you have CKD, there will be regular ups and downs in the creatinine and the urea based on various factors. So that's why a single value of creatinine or just 2 values of creatinine cannot be used for comparison. So that's why we're relying more on the GFR staging and the assessment of progression. Now, once it is CKD, it's not about one value of GFR. It's now a lifelong problem of the patient. So we need to constantly keep monitoring. And because creatinine is influenced by various factors, we rather go by GFR when it comes to CKD. But in acute cases, creatinine is more than enough. So we don't have to go for the GFR estimation. And now tell me, what are the factors that influence the creatinine values? The creatinine values are used as a marker of renal function with an assumption that the muscle mass is constant. Where is the creatinine produced? It is produced by the muscle metabolism. Creatine gets converted to creatinine whenever the muscle does activities. Right now, you might have seen a lot of gym people use creatine as a supplementation so that muscle activity gets better and they will have more strength to do gym workouts. And that leads to formation of creatinine. So creatinine is a byproduct of muscle activity. If muscle mass increases, the creatinine levels will increase. So it's not a constant value. It's not purely dependent on kidney function. The muscle mass does influence creatinine values. In fact, patients very lean, they may have lower than normal range of creatinine values. And patients who are taking creatine supplementation, they will also have high creatine. So there is an assumption when we are using creatine that the muscle mass is constant. So in acute kidney injury, within 1 day or within 2 days, nobody's muscle mass is going to fluctuate. So today I am having this much muscle mass. Tomorrow my muscle mass is not going to become half for the creatinine values to change. So if creatinine values change in a very short span of time, it's only because of renal dysfunction. But if we are talking about the long-term changes in creatinine, then it could be because of the muscle mass change also, because Muscle mass can change in long term. Patients with CKD not having appetite, decreased protein intake, they start losing muscle mass, and that loss of muscle mass will also bring down the creatinine. Or if they gain muscle mass, it will increase the creatinine. So creatinine alone is not a good marker to assess the kidney functions in the long run. So that's why we have to use GFR. And then again, when it comes to GFR, today we are not preferring the GFR estimation methods which are solely based on creatinine values. We are also taking into account the cystatin C based values. Cystatin C does not get influenced by the muscle mass, because muscle mass does fluctuate when we monitor patients for years together, and that's why we don't want to use those GFR estimation equations which are purely dependent on creatinine, like this Cockcroft-Gault formula, which is purely based on creatinine. Rather use a formula which takes into account creatinine along with that cystatin C as well. Okay, so that's it from me on the AKI CKD module on nephrology. So we'll wind up today. Tomorrow we will have gastroenterology. There's nothing much from medicine when it comes to gastro. It's all about surgery. We will try to address some of the important topics from gastro, like the celiac disease, the tropical sprue, and a little bit about IBD, peptic ulcer, and other things. I will leave it to Dr. Sandeep to cover. What else you need to study from nephrology apart from AKI and CKD? The glomerular disorders. For that, in your path books, you get a table of different glomerular disorders. What is the site of deposition of immune complexes? Majority of the glomerular disorders are immune complex deposition disorders, like PSGN, IgA nephropathy, lupus nephritis. So you just have to by heart that table and just replicate the template. You will get the glomerular disorders in the Farre notes as well, and the table. And if you want that table, just let me know. I will DM it to you on the Insta. The table will have the glomerular diseases, the site of immune complex deposition, key clinical features, and the management. And the same template you can replicate for any glomerular disorders. Teachers will be only looking for whether you know where is the site of deposition of immune complexes, what are the key microscopic findings, key clinical presentation, and management, right? So that's it for me today. I'll see you tomorrow. Till then, have a good time. So bye-bye. Good night.